Hi, my name is Holly Campbell, and I will be discussing pain management on the patient we saw in the simulation. Pain is unpleasant and can take many forms. Pain is both physical and emotional. For a postpartum mother, pain is inevitable. These changes in your body, such as sore muscles, afterbirth pains from the shrinking of the uterus, breastfeeding discomfort, vaginal pain and soreness, and for the cesarean patient, abdominal or incisional pain or referred pain. Therefore, pain medications need to be offered to these patients. There are 3 types of pain relieving medications that are used to relieve obstetrical pain. These medications are, number 1, simple medications such as Panadol. Number 2, anti-inflammatory such as Motrin or Voltaren. Number 3, opioids such as oxycodone, tramadol, and morphine. These medications work in different ways, so it is usually safe to take more than one at a time. Combining these different medications may give better pain control, allowing lower doses to be used. At our hospital, our standard medications are 800 milligrams of Motrin every 8 hours for postpartum patients with 1 to 2 Percocets, 325 milligrams, every 4 hours as needed for pain. Part of the education is to educate the patient that they must ask for the Percocet, but the Motrin will be scheduled during their postpartum stay. They will also get a prescription of Motrin at discharge. For this patient, she stated that Motrin hurts her stomach. I would ask her, had she taken the Motrin on an empty stomach? Because if that's the case, you can get a little nauseated from that. I would ask her if she would eat a few crackers and let's try the Motrin and see how she feels. If it does irritate her stomach, I would call the physician and change the order, possibly Voltaren. Other pain relieving measures I would perform are ice packs to the perineum, splinting for the cesarean mother, and lactation to come see the patient who's breastfeeding daily to inspect the breast and observe the feedings. For this patient in the simulation, she has a history of drug use and is homeless. First and foremost, if I were her nurse, I would make sure the physician knew she is homeless and has abused drugs in the past before the pain medications were ordered. It is important we are all on the same page and not enabling our patient, but also not having them suffer. Patients with a history of substance abuse are less likely to receive adequate pain management than individuals in the general population. Some of the challenges that physicians face with patients with a history of drug or substance abuse include distinguishing between seeking pain relief and seeking drugs for euphoric effects, and identifying predictable neuroadaptations such as tolerance and physiological dependence that can be misinterpreted as drug seeking or relapse behavior. With this patient, non-opioid and non-psychotropic pain medication relief options should be utilized first to provide pain relief. However, when effective pain management cannot be achieved by these measures alone, the use of opioids and other psychotropic medications is warranted. As her nurse, I would first apply the comfort measures such as the cold peri pads I spoke of. I would educate her on her medications. I would say she would be getting a high-dose Motrin around the clock. That is usually enough for the cramps and perineum pain she will be experiencing. I would continue to tell her if she feels the comfort measures with the Motrin or Voltaren is not enough, we could call the doctor and reevaluate her pain management plan. Being that she has a drug history, I would be reluctant to offer Percocet with the possibility of her wanting that right away before trying the non-opioid options. Since this patient is homeless, I would make sure she has plenty of our ice peri pads and mesh panties to be sent home with. I would also have our case manager get involved to get her the resources she needs that she can get her medications filled. What is sad but true, and many of the physicians just write prescriptions and leave. It then becomes a patient's job to get them filled. Well, if you are homeless and you have no money, how can you get your prescriptions filled? This is why I would utilize the case manager to make sure the patient has adequate pain relief once she is discharged from the hospital. In the video, the nurse says to follow up with the doctor in a few weeks if she needs something stronger for pain management. My only hesitation here is that much of the literature I found states that one doctor needs to be prescribing the pain medications. To minimize abuse potential, it is important to have one physician provide all pain medication prescriptions, as well as reduce the opioid dose to a minimum effective dose. Be aware of the tolerance potential, wean periodically to reassess pain control, and use non-psychotropic pain medications when possible. With this statement, I would recommend that the physician only give her a certain amount of Percocet as a one-time dose and allow her primary care physician to take over further narcotic pain management. If the patient does not have a primary care physician, we can use our case manager to help her find one, such as the Bon Secours Caravan, which is used as a PCP for people with a certain income. In this simulation, it is important to start with comfort measures and work our way up to the opioids. If at all possible, trying to stay clear of the opioid or a lower dose in conjunction with an anti-inflammatory would be ideal. We do not want to enable our patients, but we also do not want them to suffer in pain. It is estimated that 5 to 17% of the U.S. population has a substance abuse disorder, and these individuals' pain are usually treated inadequately. Regardless if the patient has a history or current drug abuse problem, it is important that we assess and address their pain. Even more importantly is that only one physician should be managing all the pain medications for any patient with a history or drug problem. Thank you very much, and I hope you enjoyed this.